Hi, I'm Jeff Solheim, and this is part of the TCRN review course series. This section is going to be all about abdominal trauma, and abdominal trauma is part of a larger section on the TCRN entitled Trauma to the Trunk. There's actually 4 areas in trauma to the trunk: chest, abdomen, genitourinary, and obstetric. So this is one of the 4 sections that falls under trauma to the trunk, abdominal trauma. So what I'm going to do throughout this lecture is I'm going to provide some what I call challenge questions. So I want to challenge you, see if you can get the answer to these questions right before I cover the material. Then I'm going to cover the material and I'll give you the correct answer and rationale at that time. In the back of the handout that comes with this video series, I actually have put all the challenge questions there in the back. So you can tear those pages out and you can take notes and mark the correct answers as one way to keep up with all of these challenge questions throughout the series. So here's the first challenge question for abdominal trauma. It's on your screen now. A patient has been admitted to the inpatient unit after falling 2 stories from a roof, sustaining a pulmonary contusion and hemothorax, treated with a chest tube. At 24 hours after admission, the trauma nurse notes bruising in the patient's flanks. This finding should raise the index of suspicion that the patient may also have which of the following injuries that may have been originally missed: A, liver laceration; B, pancreatic injury; C, diaphragmatic tear; or D, rupture of the small bowel. Now we're going to come back to that question when I get through that material, and I'll ask you, or I'll give you the correct answer at that time. So let's just talk a little bit about overlying principles having to do with abdominal trauma. When we look at penetrating trauma, so gunshots and stabbings and the like, you can see on the screen the incidence of abdominal organs that are injured from first to third. The small intestine is the most likely to be injured in penetrating trauma, followed by the colon, and the liver is number 3. Whereas in blunt trauma, the spleen is the most injured organ, 45 to 55% of the time. In fact, in 2/3 of abdominal trauma, the spleen is the only injured organ. The liver is the second most likely injured in blunt trauma, 35 to 45% of the time, and the small bowel is third at 5 to 10% of the time. Now, when we talk about penetrating trauma for a moment, stab wounds are 3 times more likely than gunshot wounds when you actually look at the incidence. However, as you might expect, a stab wound tends to be less lethal than a gunshot wound. With stab wounds, the upper quadrants are more likely to be injured because most people come up and under. So they stab in this direction, so the upper quadrants are more likely to be affected. And because the majority of assailants are right-handed, the left upper quadrant is the most likely to be affected. The external wound of a stab wound can be very misleading. You know, when the stab is done, if the patient or the assailant were to move when the knife is in, the blade may go up and down and cause significant underlying trauma but leave you with a very small surface wound. At other times, the knife may go in and leave a nasty gouge, but it may push everything back and not puncture it. And so you can have a nasty external wound but have very little internal trauma. So that's a long way of saying that external wounds associated with trauma can be very misleading, and you never know what's going on underneath. It may not look as bad as it is, or it could look worse than it is, and you just don't know by looking at the wound alone. That's why CT scans and exploration of the wound are so important. In fact, if you look at the statistics now on your screen in the white box, only 2/3 of stab wounds actually go through the peritoneum. A full 1/3 may only be surface trauma with no peritoneal injury. Now, of the 66% that actually penetrate the peritoneum, only about a half to 3/4 actually cause either vascular or visceral injury. So even if the peritoneum is involved, as many as half of those patients may have no injury inside the peritoneum itself. So as you can see, stab wounds can be very misleading. But remember, they can be misleading either way. What may look like a trivial wound on the surface could be catastrophic underneath if the blade moved. Gunshot wounds, on the other hand, are almost always serious. Because of the speed, they're usually going to penetrate and cause damage to multiple organs. 85% of gunshot wounds to the abdomen will penetrate the peritoneum, and 68 to 94% of those will result in significant abdominal trauma. So gunshot wounds should always be treated as though they were serious, because the majority of them will be. A couple other notes about penetrating trauma. Any trauma below the nipple line should be worked up as both abdominal and chest trauma, because remember, the diaphragm moves as high as the nipple during exhalation, and then as low as the lower rib cage during inhalation. So you have a section of your chest between your nipple line and your rib, and the bottom of your rib cage, that can be an abdomen at some times and a chest at other. So stab wounds or gunshot wounds to that middle area should be worked up as both abdominal and chest trauma, because of the way the diaphragm changes that area during inhalation and exhalation. Impalement injuries, I think this is an obvious statement, but I'll make it all the same, carry a much higher rate of infection, because of course the bacteria with the impaling object can lead to infections deep in the chest and deep. Let's move from penetrating trauma to blunt. Let's talk about seatbelt injuries, which of course would be involved in blunt trauma. Seatbelts, even when properly worn, can result in injuries. Shoulder restraints. If you think about it, on a driver, the shoulder restraint sits this way, and it's going to come across the right side of the abdomen. So if the patient's thrown forward in a high impact collision, the shoulder restraint can cut into the right side of the abdomen, leading to liver trauma. Whereas passengers, of course, the seatbelt goes the opposite way. It goes over the left side of the abdomen, and so the spleen is more likely to be injured if the patient's thrown forward into the shoulder restraint. So drivers are more likely to have liver injury. Passengers are more likely to have splenic injuries. Another problem we can see with seatbelts is improperly worn seatbelts. Some people will take their shoulder restraint and put it behind them for comfort. And then, of course, if they're involved in a collision, they're going to accordion down on themselves, like you see in the picture, and that can result in compressive injuries to the lower abdomen. As the lap belt rides over the iliac crest and digs into the abdomen, we can see significant increased intra-abdominal pressure, we can see diaphragmatic tears, we can see bowel injuries, and we also see L-spine fractures as the patient accordions down on themselves, like you see in the picture. L1 to L3 fractures are the most common in this mechanism, and they're also known as chance fractures, and it's just from the ligaments being pulled in the lower back as the patient comes down on themselves. Seatbelt injuries can be sometimes recognized by external trauma. We call it the seatbelt sign. When patients come in to the hospital and they have either redness early after the trauma or bruising later on across the iliac crest where the lap belt sits, they have actually a very high chance of sustaining intra-abdominal injury. In fact, if we look at statistics, 1/3 of people who have external trauma where the seatbelt sits on the lower abdomen, 1/3 of patients with external trauma like bruising or redness over the iliac crest or the lower abdomen, 1/3 will have small bowel injury or mesenteric tears. That's a pretty high percentage when you stop to think about it. 1/3 of people with trauma to the lower abdomen will have bowel injury or mesenteric tears. And those patients are at a high risk of what I just talked about, the chance fractures or fractures of L1 to L3 as the ligaments are pulled in the lower lumbar spine as the patient folds forward during the incident. So anytime we see external trauma on the abdomen, look for mesenteric tears, small bowel injury, and fractures of L1 to L3 or chance fractures. Now let's talk about the assessment of the patient with potential abdominal trauma. The first thing you need to consider when you're doing an abdominal assessment is whether other injuries may alter your abdominal assessment. If the patient has other distracting injuries like severe limb trauma that causes them extreme pain, they may not notice the less acute abdominal pain even during assessment, because the more distracting injury, like for example a mangled extremity, may hurt worse than the abdomen, and they may fail to recognize their abdominal pain. So consider the fact that with distracting injuries, especially painful ones, the patient is less likely to have an abdominal assessment that reveals injury. Of course, if the patient has a spinal cord injury, especially with paralysis and loss of sensation, the abdominal assessment may become very different because they can't feel the abdomen. If the patient is diabetic, they may have neuropathies, and that can decrease the acuity of their pain. If they've been using alcohol or drugs, have you ever taken care of a trauma patient who's used alcohol or drugs before the trauma? Sure you have. Obviously, they are less likely to be able to focus on the pain in their abdomen. Patients with head injuries may have a reduced LOC, decreasing the accuracy of abdominal assessment, especially for pain. And then patients with pre-existing psychiatric conditions may also have a decreased ability to recognize pain in their abdomen. So always consider those possibilities when doing an abdominal assessment, and when those exist, you may need to look for other diagnostic tests to rule in or out injuries because of the decreased effectiveness of the abdominal assessment. One of the first things you should consider when doing an abdominal assessment is the patient's history. Has the patient had nausea or vomiting since the trauma? Nausea and vomiting is frequently associated with peritoneal irritation. So ruptures of the bowel, in which they have bowel content spilling in the perineum, or bleeding from any abdominal injury into the peritoneum, can stimulate nausea and vomiting. So nausea and vomiting often indicates peritoneal irritation. It can also be associated with hypovolemia and obstructions. Now, it might seem odd to talk about obstructions in a trauma course, but remember, a patient with abdominal trauma, one that's been punched in the abdomen or an airbag in the abdomen, may develop hematomas in the bowel that can present several days later as an obstruction with nausea and vomiting. So it's not out of the realm of possibility. Another point in the history that should be considered with abdominal trauma is dyspnea. Dyspnea in the patient with abdominal trauma may be associated with gastric distension, irritation of the diaphragm, or a diaphragmatic tear, especially if bowel is spilled up into the chest. So anytime there's dyspnea, consider those possibilities. You should inspect the abdomen. If it's obviously distended, such as the patient on the screen, consider a pneumoperitoneum or air in the peritoneum, which would indicate a rupture of one of the hollow organs. Consider gastric dilation, consider an ileus, or consider a hemoperitoneum. However, note that to have actual distension of the abdomen from blood in the peritoneum, you have to have lost several liters of blood. So that's a very late finding, is the actual distension, and will usually be associated with significant hypovolemia at that point. Blood outside of the peritoneum, so bleeding especially from things that are behind the peritoneum like the pancreas, the duodenum, and the kidneys. Now that's not going to cause abdominal distension because the blood's not in the peritoneum. So instead of abdominal distension, the blood will tend to accumulate first in the flanks, and then it will come up around and gather around the belly button. And these patients may end up with bruising in the flanks, also known as Gray Turner sign, or bruising around the umbilicus, Cullen sign. Those are indications of retroperitoneal hemorrhage, or hemorrhage of organs behind the peritoneum. Note, however, that these signs are going to be delayed, because remember, it takes a while for blood to discolor. So you may not see bruising in the flanks for up to 12 hours later in injuries in the retroperitoneal space. So that brings us to the challenge question I started with. Did you get it right? Let's read it one more time. A patient's been admitted to the inpatient unit after falling 2 stories from a roof, sustaining a pulmonary contusion and hemothorax treated with a chest tube. At 24 hours after admission, the trauma nurse notes bruising in the patient's flanks. This finding should raise the index of suspicion that the patient may also have which of the following injuries which may have been originally missed. A, liver laceration, B, pancreatic injury, C, diaphragmatic tear, or D, rupture of the small bowel. I'm hoping at this point that this is obvious. Did you get pancreatic injury? Remember, the pancreas is a retroperitoneal organ. Bleeding from the pancreas will tend to accumulate in the flanks and even around the belly button, leading to bruising. So the best answer here is on questioning pancreatic injury. Your liver lacerations and ruptures of the small bowel are more likely to cause blood to accumulate in the peritoneum, giving abdominal distension as opposed to flank bruising. Diaphragmatic tears, on the other hand, are more likely to cause bowel sounds in the chest and other findings that are covered in the chest lecture of this series. All right, here's a new challenge for you. Can you get this one right? Which of the following mechanisms of injury is most likely to result in trauma to the stomach? A, gunshot wound to the mid-abdomen. B, fall from 25 feet landing on the left side. C, airbag deployment resulting in sternal fractures. Or D, increase in intra-abdominal pressure from a lap belt. Think about that for a minute. See if you can get it right. I will give you the answer when we get to that slide in a few moments. All right, let's go back to abdominal assessment now that the question is done. Auscultation. When you auscultate, if there's decreased or absent breath sound, or not breath sounds, bowel sounds, then consider the possibility of either fluid or blood in the peritoneum. Irritation of the peritoneum from fluid or blood can decrease or even cause bowel sounds to be absent. Also, consider an ileus when there's no bowel sounds. And an ileus may be caused by things like spinal cord injury that decreases innervation to the gut, or peritonitis. Palpation. Palpation should elicit tenderness in 90% of alert patients with intra-abdominal visceral injury. So there's no question that an important part of doing an abdominal assessment is good palpation, because you're going to pick up on injuries a majority of the time. One thing to note is that pain in the abdomen is often referred from one quadrant to another. So to improve accuracy of palpation, you should always palpate in the area most distal from the patient's pain. So if the patient has pain in the left lower quadrant, you want to start palpating in the quadrant most distal, which would be the right upper quadrant, and so on. Now, if the patient has tenderness in the right upper quadrant, consider trauma to the liver, gallbladder, or duodenum. If the patient has pain in the left upper quadrant on palpation, consider trauma to the spleen, stomach, or pancreas. And if the patient has tenderness to the lower abdomen, consider trauma to the colon, bladder, or urethra. One special finding to note on palpation is rebound tenderness. Rebound tenderness is where when you palpate deeply on the abdomen and then let go, the patient notes that the pain is worse when you let go. And rebound tenderness is a sign of peritoneal irritation. It could be blood in the peritoneum, chemical peritonitis from a rupture of a hollow organ, enzyme spillage from a pancreatic injury, or bacterial contaminants from a bowel injury. So those would be things that would cause rebound tenderness. Percussion. I know this is not a skill that we often use, especially in a noisy, busy trauma room. However, if you get questions on the TCRN, you'll want to be prepared for percussion-related questions. Tenderness when percussing is a peritoneal sign that indicates peritoneal irritation, and it should be further evaluated. Now, if you percuss and note dullness over a hollow organ, such as the left upper quadrant where the stomach is hollow, I expect tympany over hollow, not dullness. So dullness over a hollow organ is an indication of either free fluid in the peritoneum or a solid mass like a hematoma. Splenic injuries, for example, can cause hematomas on the front wall of the abdomen and give dullness to percussion over the area where you should have tympany with the stomach. Now, hyperresonance over solid organs, in other words, hearing tympany or hyperresonance over an area that should normally be a dull thud, indicates free air in the abdomen and a likely rupture of some hollow organ. Fixed areas of dullness, where you have a dullness that suddenly ends at a very clear distinction point, often indicate a hematoma. So bleeding from specific organs, for example, dullness in the left upper quadrant from a splenic rupture could indicate a hematoma from the spleen. We actually use that's called balance sign, and you can actually use percussion over the left upper quadrant, and you measure the inches of dullness to percussion in the left upper quadrant, and that would give you the size of the hematoma and the degree of bleeding from the spleen. It's called balance sign. And then dullness that does not change when the patient changes position is an indication of a retroperitoneal hematoma. So those are some of your findings with percussion. Another diagnostic test that is, of course, done by an advanced and experienced practitioner is a FAST exam, a focused abdominal sonography for trauma, or a bedside ultrasound. FAST exams are specifically useful for detecting blood in the peritoneum. In fact, as little as 100 mL of blood can be detected by a good practitioner. You can also use a FAST exam to determine pericardial fluid or a pericardial tamponade. It can pick up on a hemothorax and a pneumothorax. Note that a FAST exam is not useful in identifying or grading solid organ injuries, so it's not going to help with splenic ruptures and liver trauma and so on. It also has very low accuracy for retroperitoneal bleeding, like pancreatic bleeding or duodenal bleeding. And injuries to the small bowel and diaphragm are not easily recognized using a FAST exam. So FASTs have limitations, but they are good for blood in the peritoneum, for hemothorax, pneumothorax, and pericardial fluid. A test that's rarely done today, but it is still considered accurate and may still be done in rare cases, especially if a CT scanner is not immediately available, would be a DPA, diagnostic peritoneal aspiration, or a DPL, diagnostic peritoneal lavage. It wasn't that many years ago that we did these all the time, but with the advent of CT scanners, they almost became non-existent, and so today they're rarely used. However, they do remain 95% accurate for detecting blood in the peritoneum. So to do these, a small incision is made in the abdomen, and then tubing is put down into the incision. Now the first thing that's done is a needle is put on the tubing that's exposed from the abdomen, and then there's a withdraw on the needle. If you get blood out, obviously there's bleeding in the peritoneum. That patient needs to go to the OR. It's very diagnostic and easy to do. Sometimes though, if your catheter is not placed right, if it's not placed in the blood, you may not get anything on DPA or aspiration, and then you do a DPL. To do a DPL, you put a liter of fluid from an IV bag, like normal saline, into the tubing that's placed in the abdomen, and then you put that bag on the floor and let the fluid drain back out. If there's blood in the fluid, you know there's blood in the peritoneum. And the way we used to diagnose these, the old saying was, if you can't read the writing on the IV bag because there's enough blood, then they go to the OR. So if there's enough cloudiness in the bag that you can't read the writing on the other side of the bag after refilling it, then the patient's going to the OR. So DPA, aspirating for blood; DPL, putting fluid in and then letting it drain out and looking for blood, are ways to detect a hemoperitoneum. If you're going to assist with a DPA or DPL, you'll want to make sure you put in a gastric tube and urinary catheter first. We want to decompress the stomach so you don't inadvertently nick the stomach when you make the incision for the DPL or DPA. And you also want to decompress the bladder so you don't inadvertently nick the bladder when making the incision. The catheter is placed in the abdomen. Again, aspiration of 10 mL or more of blood, bile, food particles, or GI contents is an indication for an open laparotomy. If the DPA is negative, then a liter of crystalloid is put in the abdomen and drained. If there's frank blood, they go to the OR. If there's not frank blood, we send it to the lab, and the lab can look at the fluid for signs of bile, food stuff, or other things in the bag that could indicate a rupture of a hollow organ. DPA, DPL, rarely used today, but there's nothing wrong with them. They can still be indicated and done. So what are the indications that a patient should go to the OR with abdominal trauma? Any patient with signs of hypovolemia or persistent hypotension for which there is no other reasonable explanation for it. If the patient is getting fluids, they're staying hypovolemic, you can't find another injury, the likelihood of abdominal injury is very high. If they have ongoing hemodynamic instability, if they require 2 or more units of blood to maintain their blood pressure, those are good reasons to go to the OR. They're probably not going to tamponade on their own. Any clear signs of peritoneal irritation like rebound tenderness is an indication for surgery. Radiological evidence of pneumoperitoneum or free air in the abdomen, because that indicates a rupture of a hollow organ. Those aren't going to heal on their own. They're going to need surgical repair. Evidence of diaphragmatic ruptures will need the OR. Persistent, significant gastrointestinal bleeding seen in the gastric tube, return, vomitus, or gross blood per rectum, and then evisceration. Many solid organ injuries like the spleen and the liver do not require operative intervention. If the patient's hemodynamically stable and they have a solid organ injury, then they may be admitted upstairs for non-operative observation. Now, patients admitted for non-operative observation of a solid organ injury like the liver or the spleen should be observed for hemodynamic stability, for stable hemoglobin levels. Those are some of your assessments. Overall, a patient may be admitted non-operatively if they remain hemodynamically stable, if their hemoglobin levels remain stable for the first 48 hours, if they need 2 units or less of packed red blood cell, if they're less than 55 years of age, and if they have no distracting injuries and can cooperate with their abdominal assessment. If they fit those categories, then they're more likely to be admitted for non-operative management of a known solid organ injury. Now, if the patient is admitted with a known solid organ injury like a splenic rupture or a liver laceration, they should be monitored on the inpatient side for progressive anemia, hypotension, tachycardia, or a base deficit that does not correct despite the administration of fluids. Those are indications that that patient may in fact require operative management, but it may be delayed. Let's talk about one complication of abdominal trauma, and that's abdominal compartment syndrome, or ACS. The peritoneum is a tight space, just like the pericardium is, or just like a muscle fascia is. It can only hold so much volume. If the volume inside the peritoneum increases, it can compress everything inside and lead to ischemia of the gut and bowel. In fact, look at all of the different things that occur when you have swelling inside the peritoneum. That swelling inside the peritoneum is going to increase pressure into the chest, which is going to increase pressure up into the head, because as the abdomen swells, it just keeps pushing everything up. So it can cause increased intracranial pressure. It can cause increased intrathoracic pressure with increased peak pressures, difficulty ventilating the patient on a ventilator. It can lead to ischemia of the organs because they're all compressed inside the peritoneum. The lack of oxygen delivery to tissue due to the swollen abdomen can lead to acidosis. The swollen abdomen will push back on the kidneys, leading to renal failure. The vena cava tends to be compressed behind the swollen abdomen, so we tend to see changes in cardiovascular output, and overall the patient becomes unstable from the cardiovascular standpoint. The bottom line is, as the edema occurs within the abdomen, the patient's urinary output will usually fall. This is an early and classic finding of abdominal compartment syndrome. CVPs and pulmonary artery wedge pressures will elevate. Systemic vascular resistance will elevate, all having to do with the abdomen swelling and pushing back against the vena cava behind it. That in turn will cause the blood pressure to drop. The swelling abdomen pushing the diaphragm up will cause decreased tidal volumes and contribute to a respiratory acidosis. So those are some of the things that indicate the onset of abdominal compartment syndrome. When we suspect abdominal compartment syndrome, it is important to measure the patient's pressures inside of the abdomen. Now, there are lots of ways to do it, but the easiest and most typical way to measure intra-abdominal pressure is a bladder pressure. I mean, even though the bladder is not in the peritoneum, it's below it. When the peritoneum swells, it's going to push down on the pelvic space and compress the bladder and make pressures inside the bladder higher. So we can measure the pressures in the bladder as an indirect measurement of pressure in the abdominal compartment. Bladder pressure should be measured with the patient lying flat or completely supine, because we want to try and stretch that peritoneum out as much as possible. It should be measured in expiration, because remember, at the height of inhalation, the diaphragm is going to push down against the peritoneum, which can increase bladder pressures. So we want to do an end expiration measurement. You should, like any time you're measuring pressures, zero out your transducer at the mid-axillary line. Put the fluid in, and the amount of fluid instilled is going to be institution dependent. Different institutions use different fluid amounts. The important part is that every person measuring pressure on each shift uses the same amount of fluid, so you're comparing apples to apples. You should measure the pressure in the bladder with the transducer through the urinary catheter. So the patient has a urinary catheter, and you've put fluid in the bladder. You have the transducer in the bladder, and then 30 to 60 seconds after putting the fluid into the bladder, measure the pressure. You want to make sure, if at all possible, the patient's having no abdominal contractions at the time, because abdominal muscle contraction can falsely elevate bladder pressures. So let me just quickly go through those steps again. Make sure the patient's supine. Measure it at the end of expiration. Make sure the transducer is zeroed at the mid-axillary line. Put the appropriate amount of fluid in the bladder. Wait 30 to 60 seconds. Make sure there's no abdominal contractions, and measure the pressure. Now, overall, pressures between 12 and 15 do not require aggressive treatment. That may indicate early onset of abdominal compartment syndrome. It's called a grade 1. And typically, if we can keep these patients euvolemic so that they can maintain a good blood pressure, they will need no further treatment. But you want to carefully monitor to make sure the pressures don't continue to climb. Once pressures hit 16 to 20, the patient will usually have a rapid decline in blood pressure, and they'll require volume to maintain their blood pressure. And we're also going to need to start seeking the cause of the ACS, or abdominal compartment syndrome, and to try to relieve it. When pressures reach 21 to 25 in the bladder, you have a grade 3 abdominal compartment syndrome. These patients will probably need to be actively decompressed. If they're post-op, we may have to reopen the wound and let the peritoneum open to let pressure out. If the patient's having, for example, bleeding into the peritoneum, and that's what's causing the pressure, they may need to have the blood drained. So a decompression is required with pressures between 21 and 25. Any pressure above 25 will likely end up back in the OR. There's a good chance that the patient probably has a hematoma in there that needs to be evacuated, or something else that has to be surgically investigated. So 12 to 15 will often do well as long as we keep them euvolemic. 16 to 20 will usually be hypotensive. They'll need fluid, and we'll also need to seek the cause to try to resolve it. 21 to 25 will usually need the abdomen opened so that we can let the pressure out, and anything above 25 is usually going to require surgical exploration to repair. Now, I've been talking a lot about bladder pressures here, but I want to remind you that there's really two things that should be factored in when you have abdominal compartment syndrome. One is the intra-abdominal pressure, usually measured at the bladder, but the other one is the MAP. If you have a patient who has a really low blood pressure, you know what? They're not going to be able to push blood into that swollen peritoneum, and you can end up with patients who have significant hypoxia of the gut, even with low bladder pressures, if their blood pressure is also low. Whereas if they have a really high blood pressure, they can probably push blood and oxygen into even a swollen peritoneum. So the higher the blood pressure is, the better the patient does. And so sometimes, instead of just measuring bladder pressures, we may actually look at the patient's abdominal perfusion pressure, or APP. APP is calculated by taking the patient's MAP, or mean arterial pressure, and subtracting it from their bladder pressure or intra-abdominal pressure. And that's actually a better indicator of how well they're perfusing the gut than bladder pressure alone. Now, if you're not familiar with mean arterial pressure, in the shock section of this lecture series, I talk about how to calculate a mean arterial pressure. So you may want to refer to that if you're not familiar with MAP. Abdominal perfusion pressure, again, is the MAP, the force that pushes it into the abdomen, and then the intra-abdominal pressure, the force that pushes it out. Ideally, you want an APP or abdominal perfusion pressure above 50. So if somebody's got a normal MAP, and normal MAPs are around 90, even if I have a bladder pressure of 25, I've still got a pretty good abdominal perfusion pressure. The only problem is my abdomen swells, my blood pressure is going to fall. So it's unlikely I'd ever have a MAP of 90 with a bladder pressure of 25. So, you know, I'm more likely to have a MAP of, say, 50 with a abdominal pressure of 25. And that, of course, is an abdominal perfusion pressure of 25, which is way too low. That's going to be ischemic bowel and all those problems that go with it. So what are the interventions for abdominal compartment syndrome? Avoid elevating the head of the bed. That's just going to increase pressure as the patient folds. Keep the patient flat. Maintain a healthy mean arterial pressure as much as possible, but remember, you don't want to be dumping crystalloids in these patients to get their blood pressure up, because where are the crystalloids going to go? They're going to leak in the abdomen and make the edema and pressure worse in there. Consider diuresis if appropriate. A lot of trauma patients are already hypovolemic, and diuresis may not be appropriate, so it's as appropriate. A percutaneous catheter may be placed through the peritoneum to drain fluid or blood out and release the pressure, and then either a bedside or operative decompression, opening the abdomen and letting everything out. On the screen you can see an amazing picture of an abdomen that's been opened with abdominal compartment syndrome. Look at how swollen the bowel is, look at how ischemic the bowel is, and look at how much came out. Imagine all that being tucked inside a tight peritoneum. No wonder that bowel is ischemic, and the patient has all the symptoms they do, right? Okay, now let's actually go organ by organ through all of the abdominal system and just talk about some of the different injuries with each of the organs of the GI system or the abdomen. So let's start actually up in the chest with the esophagus. This is a rarely injured area of the GI tract, and if it is injured, it almost always involves other areas of the chest. It's rarely a single system injury. Most injuries occur in the upper section of the esophagus, the cervical region. The lower areas of the esophagus are much more protected and less likely to be injured. So most people who injure the esophagus will injure in that upper area. It's most common in penetrating trauma, so gunshots to the chest. Because of the depth of the esophagus, it's rarely injured in blunt trauma. And typically when the esophagus is injured, there's going to be fluid losses from the GI tract into the thorax, causing respiratory distress and a lot of respiratory symptoms. Some of the symptoms that give away esophageal trauma, well, of course, fluid spilling from the esophagus into the mediastinum is going to cause pain in the neck, chest, shoulders, and throughout the abdomen. The patient will usually have pain on swallowing. They may have fever, but that has to do with chest infection, so that would be delayed. They may have signs of peritonitis, and they could have dyspnea or pleural pain because of the affect of the chest. The treatment, consider a gastric tube. Now obviously that has to be done with caution. If there's a rupture of the esophagus, you don't want the tube to feed out into the mediastinum, so with caution, gastric decompression. Antibiotic therapy early because of the infections of the chest, and for the most part, any esophageal trauma is going to end up in the OR to repair the esophagus, to clean out the chest, and try to reduce the amount of post-op infections. Some of the long-term complications associated with esophageal trauma on the inpatient side: peritonitis, respiratory compromise long-term, fistula formations in the esophagus, and esophageal strictures. All right, let's go down now to the stomach. The stomach is very rarely injured. It's up under the rib cage, so it takes great force to get to the trauma, to get to the stomach. Therefore, in blunt trauma, the stomach is only injured about 1% of the time. It's just high and protected. Now, penetrating trauma, especially stab wounds, because remember, right-handed assailants go up and under the left upper quadrant, affect the stomach 20% of the time. Now, overall, there isn't a lot of bacteria in the stomach because of all the acidity there. So the patients who have stomach injuries are not maybe as high a risk of developing bacterial infections because they have very little bacteria growth in there. Do remember that the stomach moves as you breathe, so and as you change position. When you're supine, your stomach is going to be up in the upper chest, whereas when you're standing, it ends up kind of down at the lower rib cage. So especially with penetrating trauma, you have to consider the fact that the stomach changes position based on your body position. Now, does that help you with the challenge question I gave you earlier? Remember, which of the following mechanisms of injury is most likely to result in trauma to the stomach? A, gunshot wound to the mid-abdomen. B, fall from 25 feet landing on the left side. C, airbag deployment resulting in sternal fractures. Or D, increase in intra-abdominal pressure from a lap belt. It's A, right? You got it right? Did you get it right originally as well? I hope you did. If not, I hope it makes sense now why that is the correct answer. Let's do another challenge question for a little bit later. A scrotal hematoma should alert the trauma nurse to a strong possibility of A, rectal trauma, B, femur fracture, C, shattered kidney, D, intraperitoneal bladder rupture. All right, I'm going to give you the answer in a few slides, but let's keep moving with stomach trauma. So symptoms that a patient may have with stomach trauma include bloody drainage in the gastric tube, free air on the radiograph, because of course the stomach is a hollow organ, tenderness, especially in the epigastric region when you palpate, and then initially the pain tends to be due to chemical irritation, the acid spilling out of the abdomen or out of the stomach into the peritoneum, but later it could be due to bacterial overgrowth. Some of the inpatient complications associated with stomach trauma, again, complications are rare if the patient goes to the OR rapidly. We can clean out the peritoneum, we can repair the stomach, and that decreases complications. But for missed stomach injuries, they're more likely to have a delayed bacterial peritonitis. They may have intra-abdominal abscess formations and gastric fistulas. All right, the spleen. The spleen is encapsulated, tightly encapsulated. It's got a capsule around it that holds really tight onto it. It's in the left upper quadrant, right under ribs 9, 10, and 11. So as mentioned in the chest trauma lecture, any fractures of the left lower ribs can result in injury to that tightly encapsulated organ. It's a dense organ. It's not very elastic or flexible, so it doesn't take a lot of external trauma to rupture the spleen, making it the most injured organ from blunt trauma. Right now, your spleen is probably storing 200 to 300 mLs of blood. So if you rupture the spleen, you're immediately going to lose that into the peritoneum. And then in addition, 250 mLs of blood will circulate through your spleen at any given minute. So if you have a large splenic rupture, you think about it, every minute 215 is going through, a lot of that spilling out of a ruptured spleen. It's not long before the blood loss can be significant, right? Now this chart, which is both in your handout and on the screen, goes over the grades of splenic trauma. I'm not going to read the chart to you. You might want to just read it to be familiar with it. Remember that if the capsule around the spleen is intact and they have a bleeding spleen, the blood will collect inside the spleen. The blood will collect inside the capsule and compress the spleen, and we call that a hematoma. Whereas if the capsule ruptures and the blood pours out into the peritoneum, then the patient has a laceration. So hematomas are contained, lacerations are not. Some of the symptoms of splenic trauma You may see surface trauma in the left upper quadrant. Now, if the capsule ruptures, then you will see blood, and there could be bruising or distension on the left upper quadrant. You may see indications of intraperitoneal bleeding like abdominal distension, asymmetry, abnormal contour of the abdomen with an increased swelling on the left side, or a tight abdomen to palpation. And the patient's most likely to experience the tenderness and guarding and rigidity in the left upper quadrant. Also, if the blood leaks from the capsule, it can irritate the diaphragm. And because your diaphragm and your shoulder share the same nerve pathway at T10, people with splenic injuries that have blood pushing the diaphragm up may actually have shoulder pain on the left side as opposed to abdominal pain. That shoulder pain is especially exacerbated if the patient's lying supine or in Trendelenburg's when the blood pushes more up against the diaphragm. The patient may have left upper quadrant pain if the capsule is stretching. If it's not ruptured but stretching, they may have left upper quadrant pain. And if they rupture, they could have rebound tenderness due to peritoneal irritation. The treatment for splenic injury is really going to depend on patient's stability. If the patient remains hemodynamically stable post-splenic injury, then they may be treated non-operatively. If, however, they cannot be hemodynamically stabilized through the administration of fluid and blood, then they'll need to go to the OR. The idea today is to try to salvage the spleen. We know the spleen is essential to fighting infection. So they'll try to pack and repair the spleen if at all possible. That's known as a splenorrhaphy, when they repair the spleen or suture it. In some cases of severe splenic trauma, when the patient has a non-salvageable spleen, then the spleen will be removed. But that is really reserved for extreme cases because we know the spleen is essential to fighting infection in the body. Some of the inpatient complications that you should watch for if you're caring for a splenic trauma patient. They can have acute gastric dilation and gastric perforation. Has to do with the proximity of the spleen to the stomach. They can have recurrent bleeding post-operatively, or even for a non-operative spleen, it can start to bleed again days later. The tail of the pancreas sits on the spleen, and so especially post-operatively, after splenic repair or splenorrhaphy, patients may develop pancreatitis. Another thing to watch for is post-operative elevations in either the white count or the platelet count. Those are to a certain degree expected post-splenectomy. They tend to spike in the hours after the splenectomy. We see sudden elevations in white count, sudden elevations in platelets. Remember that that's what the spleen stores. But typically those should return to normal by about the 4th day post-op. If especially the white count doesn't return back to normal by day 4, then consider the possibility of an infection and sepsis as the cause of the elevated white count rather than the splenic surgery itself. One delayed complication to consider is that the spleen that initially was stable will just spontaneously rupture in the days after this injury. They can have the unstable spleen can just rupture and then the patient will bleed out. Sometimes these patients may not even have a known splenic injury. The spleen may be injury, but they come into the trauma unit stable, and then 24, 48 hours later the spleen ruptures and they bleed out. This is a rare complication, but it is a complication to be aware of, is a spontaneous rupture of a spleen that's treated non-operatively. A couple of long-term complications that need to be considered with splenic injury. If the patient has a splenectomy, they really have no other place in the body in which to fight encapsulated bacteria. So if they develop an infection by an encapsulated bacteria like pneumococcus, meningococcus, E. coli, Haemophilus influenza, staphylococcus, or streptococcus, now you have no ability to fight these infections and they can overtake and kill you in short periods of time. So we want to make sure these patients are vaccinated post-operatively for all of these infections, that they get their vaccinations every 5 years, and that they know as part of their discharge teaching to report immediately to their healthcare provider or the emergency department for any flu-like symptoms, high fever, or signs of shock. These patients can develop meningitis, pneumonias, and bloodborne infections very rapidly, and they have no way to fight them. So they're at high risk and need special teaching regarding vaccination and the need to return to the ER for any signs of infection for the rest of their lives. All right, the liver is the largest abdominal organ. It actually weighs between 3 and 4 pounds. It lays under ribs 6 to 10 on the right. And it crosses the midline, so there's a little bit lying on the left side under ribs 7 to 8. About 13% of your blood is in your liver at any given time. Stop to think about that. 13% of your blood's in your liver at any given time. Imagine a huge arterial laceration of the liver, and 13% is going through there constantly, and that's spilling out into the abdomen. Yeah, that's why these patients can die. Other things the liver does is metabolize fats, including vitamin K, that helps produce clotting factors. So liver injuries can also contribute to clotting abnormalities and coagulopathies. Now, just like the splenic injury, here's a chart that I've put in your handout on the grading of liver injuries. I'm not sure how much this would actually be tested, but I wanted to provide it to you for your own reference, so you can review this chart in your handout on your own. Some of the symptoms of liver injury: tenderness and guarding and rigidity in the right upper quadrant, especially if there's a rupture of the capsule around the liver. Elevated liver function tests, they're directly correlated to the degree of liver trauma. The higher the LFTs go in the hours and days post-trauma, the more liver damage there is. Ecchymosis around the umbilicus. Remember that your umbilicus is continuous with the peritoneum because of the prenatal cord, and so because of that continuous, bleeding in the peritoneum can result in bruising around the umbilicus or the right upper quadrant, and then because of the significant blood loss, patients can actually have a distended abdomen. But remember what I said earlier, it takes a couple liters of blood for the abdomen to be distended. So if they come in with big tummies, consider the fact that they probably are dealing with significant hypovolemia at that point as well. The medical treatment for liver trauma, most of your patients are going to be non-operatively managed unless they're hemodynamically unstable. But if they are clotting off their own liver, and most livers have clotted off by the time they got to the OR anyway, so if the patient can be stabilized with blood and fluids, they remain hemodynamically stable, then we may admit them for observation, which we talked about earlier. Sometimes we can non-operatively treat the patient with embolization, going up through the femoral artery and then embolizing or packing the area of bleeding. And in severe cases with hemodynamic instability, surgical repair is required. Some of the long-term complications to monitor for with liver trauma include recurrent bleeding. Up to 3 to 7% of patients will bleed again. And this may require embolization or a reopening of the abdomen to fix the bleeding site. These patients can develop intra-abdominal abscesses. Typically, abscesses are treated with a CT-guided drainage or reoperation. And they can develop biliary fistulas like you see on the screen. And it's defined, a biliary fistula is defined as greater than 50 mLs of biliary drainage per day for over 2 weeks. Most deaths that occur from liver trauma occur in the early postoperative period. When we say early, it's 48 hours or less, and they're related to shock or transfusion-related coagulopathies because of the amount of blood needed to treat a serious liver laceration. The pancreas is about 20 centimeters long. The head is on the right at touching the duodenum, and the left goes all the way, the tail, goes all the way over to the left and touches the spleen. So it's a long, long organ that really goes along much of the abdomen. The body is between the stomach and the spinal column, so it's way back there. It's well protected. It takes significant force to actually get back to, which is buried deep in the abdomen and up under the rib cage at that. Because of that isolated protection, it is rarely injured, but it is tucked up against the vertebral column. So if there's enough pressure to injure the pancreas, consider the possibility of the vertebrae and the spinal cord being injured as well. And also, because the pancreas is tucked into the corner of the duodenum, pancreatic injuries are frequently associated with duodenal injuries. Now, because of its high position in the back under the rib cage, it's a rare injury, between a 3 to 12% injury rate. But because of its depth and the force it takes to actually get to it, when it is injured, it carries mortality as high as 50%. It is more common in penetrating trauma because penetrating trauma goes deeper than blunt trauma. Some of the symptoms of pancreatic trauma. The pancreas doesn't have really sensitive sensation or nociceptor fibers. Therefore, it can be a pain-free injury for many hours. Patients can have significant pancreatic trauma but have no pain until the pancreatic juices start spilling out of the injured pancreas and injuring and inflaming the tissue around it. Then the pain starts. But that can be hours or even days later before the pain starts. The pain will often radiate from the epigastric region through to the back. If you palpate the abdomen, there may be tenderness to deep palpation, and amylase levels will tend to rise. However, it can take 6 hours or more for those to rise. So for that reason, pancreatic injuries may be missed initially because they're painless, they don't have a lot of lab changes, and so we tend to see a delayed finding of pancreatic trauma. A lot of pancreatic trauma is non-operatively managed. Complete bowel rest, so of course NPO, nutritional support in other ways, and serial CT scans to assess for the onset of pancreatitis and hematomas around that injured pancreas. These patients are at high risk for developing pseudocysts because of the pancreatic enzymes that may be released from the injured pancreas, so we need to monitor for those. And pancreatic ductal injuries may result in the patient having to have a distal pancreatectomy. Some of the complications to monitor for with pancreatic injury include secondary hemorrhage days later, pancreatic fistulas and abscesses from the pancreatic juices. Pancreatitis can occur in the days following pancreatic injury. And infection, most common 7 to 10 days after injury, marked by fever, elevating white count, nausea, and vomiting. The duodenum. The duodenum comes, off the stomach and then goes into the small bowel, tucked around the head of the pancreas. When it is injured, it's frequently associated with pancreatic trauma just because of their proximity. It may also have injuries of the bile duct and vena cava as well. Now, the duodenum is not inside the peritoneum. It goes around the back, outside the peritoneum in the retroperitoneal space. Therefore, injuries to the duodenum are not going to cause the classic peritoneal signs of abdominal trauma that we expect. They're more likely to have signs of retroperitoneal trauma. So some of the symptoms of a duodenum injury. Now, these injuries may go unnoticed first, depending on their severity. They may develop hematomas in the duodenum that will take hours or days to develop, and the patient may come back as a bowel obstruction with nausea, vomiting. If they actually perforate the duodenum, typically because of the acid in the duodenal area, they can have acute pain and tenderness. All right, moving now from the duodenum to the small bowel. The small bowel, once you've passed the duodenum, the pancreas empties into the bowel and neutralizes all of the chyme from the stomach. And so anything below the duodenum is going to have a neutral pH and be relatively sterile from the acid of the stomach. For that reason, small bowel trauma may go unnoticed because the patient doesn't have the acidity in the stomach and they don't have the bacteria because of the acid of the stomach. Therefore, even with significant bowel trauma, some of the symptoms we expect may be delayed or absent. Common points of injury are parts of the bowel that are fixed. The ligament atretes, which occurs near the duodenum, and the ileocecal valve are fixed points where they're held to the back wall of the abdomen. So while a lot of the bowel may move forward, these won't, and those are common points of injury. Like the duodenum, Hematomas inside the bowel may develop days later and result in bowel obstructions as a delayed presentation. Spinal cord injuries, like the chance fractures I talked about earlier, may decrease or take away the complete sensation of the abdomen, making the findings of a small bowel injury difficult if the patient has these spinal cord injuries. Some of the symptoms of small bowel trauma: the patient may have muscle spasms or rigidity either in the epigastric or left upper quadrant. The small bowel is hollow, so you may see free air on the x-ray like you see in that x-ray on your screen. You can see how the diaphragm is lifted up as air escapes from the small bowel into the peritoneum and pushes the diaphragm up, and you can see the diaphragm there above the liver and stomach. They may have that seatbelt sign I talked about earlier, abrasions or bruising across the iliac crest. The blood loss can cause tachycardia, hypotension. If a DPA or DPL is done, there may be bile or food fibers in there. They may have rebound tenderness and guarding because of peritoneal irritability, and an elevated white count, amylase, and metabolic acidosis on their labs. Now, non-operatively, patients who have no signs of peritonitis, who remain stable hemodynamically, may be admitted for observation only. And then, of course, we're really looking there for the onset of peritonitis, the onset of bowel obstructions, and the onset of hypovolemia, and treat them as they occur. If the patient has, a ruptured bowel, signs of peritonitis, or they are hemodynamically unstable from blood loss, then the operating room is appropriate. Some of the inpatient complications to monitor for in small bowel trauma include wound infection and abscesses because of the contamination from the ruptured bowel, fistula formations, small bowel obstructions that may be delayed, ischemic bowel that can lead to abdominal compartment syndrome, suture line leakage, and short gut syndrome with dumping syndrome. The large bowel, you got your three sections, right? The ascending, the transverse, and the descending colon. And if you were watching the video, I just did that backwards. The ascending, the transverse, and the descending. The transverse colon is the one that has the least amount of protection around it. So it's the most likely to be injured. 17% of penetrating trauma will affect the large bowel because of the size. The large bowel contains anaerobic bacteria used to break down food. When that bacteria is released from the ruptured bowel, the patient's at a much higher risk of developing sepsis. So we can see intra-abdominal infections, peritonitis, and sepsis as a long-term complication of the large bowel. Now, part of the colon is behind the peritoneum. So retroperitoneal colon injuries are more likely to have a delayed onset of symptoms, and they're more likely to manifest as abdominal tenderness or signs of infection. And these are more common when you have penetrating trauma to the back. So some of the symptoms of a large bowel trauma. Okay, if the large bowel is eviscerated like that picture, you can assume small bowel trauma or large bowel trauma. Let's go with that, right? The bleeding from the large bowel can lead to hypovolemic shock, and the patient can have signs of peritoneal irritation. The rectum, of course, the very end of the large bowel. When the rectum is injured, bleeding may show up either from or around the rectum. So the patient can have the bleeding down in that lower pelvic area. They can have rectal bleeding. Or the blood may run down into the scrotum, more in males than females. You can get the scrotal hematomas. And then the patient may have immediate signs of peritonitis because of all the fecal contamination in the bowel, especially with anterior lateral wall injuries. So that brings us to our challenge question. Remember, a scrotal hematoma should alert the trauma nurse to a strong possibility of, and I'm sure this is obvious now, rectal trauma, femur fracture, shattered kidney, or intraperitoneal bladder rupture. The right answer is rectal trauma. The treatment for injuries to the large bowel, the goal is early recognition to reduce fecal contamination and sepsis. So we really want to find and treat the bowel injuries soon so they don't end up with peritonitis and sepsis. Preoperative antibiotic therapy is used to reduce the secondary infections due to the contamination from the bacteria of the large bowel. Significant injuries will require irrigation of the peritoneum to remove fecal material, primary bowel repair, including resection and anastomosis, and a diverting colostomy. Rectal injuries will require colostomy and a distal rectal washout. Some of the inpatient complications associated with bowel trauma include incisional infections because of the fecal contamination during surgery, intra-abdominal abscesses, and fecal fistulas like the one on the screen. Well, I hope that information is helpful and will help you to be successful in navigating the abdominal trauma questions on the TCRN. Best of luck on those questions.